AV fistula and veno-venous fistulas too. Lateral tunnel is quite common because it was the preferred choice in 20, 25 years ago, in 2 decades ago. But in youngest patient, we now have extracardiac conduit. The difference between atriopulmonary and extracardiac conduit from atriopulmonary passing through lateral tunnel, the stiffness of the conduit means higher pressures in the long-term follow-up patient. Extracardiac conduit, in my experience, is more prone to hepatic congestion, liver cirrhosis, and PLE once the resistance in the pulmonary arteries increase over the time. That is a known complication in long-term follow-up of Fontan tracks. For this reason, vasodilators should be considered in these patients. You know that in literature there are conflicting data about this. For this reason, in our center, we always do a cut and collect all hemodynamic data before proceed with pulmonary vasodilators, because it's important to discriminate patient with high resistance with patient with an increased post-capillary pressure, because of course the effect of the drug is quite different, because it can be effective in patients with a lower pulmonary compliance, but can be harmful in patients that are developing post-capillary, so a diastolic dysfunction of the single ventricle. And sometimes by echo, disease can be difficult to be assessed. So, of course, a mainstay of pulmonary Fontan track is to optimize it. So often we have problems of pulmonary artery stenosis. It is quite common when surgical maneuvers are provided on the aorta, in case of Damos-Kay or an Nordwood procedure. So in this setting, the first aim is to optimize the Fontan track, and stent implantation is a common maneuver, mostly in left pulmonary artery. In this case, the aorta was quite huge, so we shaped the stent by using a bivascular approach, jugular vein and femoral vein, in order to shape the septum either from Fontan conduit and from Glenn anastomosis. And the final result seems to be good. Of course, procedure can be complicated by vessel damages. In this case, we had a rupture of the left pulmonary artery, and due to the presence of residual stent mesh, we treated it with a covered stent, of course, and the procedure was effective. And another point might be the conduit stenting. This is a severely stenotic extracardiac conduit in a Kawashima track. In addition, here you can see that there was a shunt across suprahepatic vein that we will see better in the next slide. Here there was a kinking, and we used two covered stents to fully rebuild the extracardiac conduit from the suprahepatic connection to the pulmonary artery connection. As I told you, in this patient there was the patency of a suprahepatic vein in the right atrium. For this reason, after stent deployment, we used the transhepatic approach to achieve an access in the liver. And once obtained it, we tried with to a balloon testing, so a balloon occlusion test to assess the pressure in the liver after the hypothetical closure of that vein. Unfortunately, you can see from this angio that was a stasis in the liver. The flow toward the stent was very slow, and the pressure increased in the liver too much so this patient was judged not eligible for correction of this disease. So we had no way to resolve the desaturation due to this shunt in this patient. More rare but quite difficult to be treated is the stenosis of right pulmonary artery, because usually the gland is just is close to the hilum of pulmonary right pulmonary artery. So a stent can be too long for this anatomy. In this case, we tried effectively to improve the diameter of the vessel. You can see that after balloon dilatation, the right pulmonary branch diameter much improved compared to baseline that we can see just now. Okay. An important topic is how to manage collaterals. You know that we can have veno-venous collaterals in Fontan track. The connection can be restored, created based on embryological remnants. This is the anatomy of pulmonary veins and coronary sinus. This is the embryology of superior and inferior vena cava. You can see that we have an apoptosis of some vessel like anterior cardinal vein and left posterior cardinal vein. Unfortunately, in long-term Fontan patient, this connection can be restored, and this is the reason of sometimes huge veno-venous collaterals. And the anastomosis might be mostly on SVC and coronary sinus, or pulmonary veins across azygos network. Of course, the veno-venous connections are more common in heterotaxy, and the main consequence is desaturation. Often the drive of this veno-venous connection is an increased resistance in pulmonary capillary bed. So these connections are like bypass for Fontan track. Other connection might be pulmonary arteriovenous connections, or systemic to pulmonary arterial connections. So these are examples of collaterals. Fontan fenestrations, this is iatrogenic, as you know. These are systemic connection from the subdiaphragmatic cardinal veins. These are connection between hepatic veins and pulmonary veins. And finally, in this setting, we have arteriovenous connection. That these are intrapulmonary connection between pulmonary artery and pulmonary vein, as you know. Pulmonary collaterals, venous collaterals are quite common. There are several, despite small studies, demonstrating that often in Fontan, about 15% in this paper, can have veno venous shunt with an output higher than 1 liter per minute. That is a huge amount, of course, and the main consequence is the saturation. This patient often below 90%. So when the saturation falls below this cutoff, the veno-venous collaterals are quite common. So the consequence of the collateral can sometimes are misunderstood. In this paper, you can see that fenestrations and collaterals were compared, where they found in this patient a lower life expectancy and higher incidence of complications and death. However, often the problem is that patients with the collaterals are high risk patients. So the collaterals are the consequence, not the reason of or Fontan failure. And this point nowadays, I think that should be highly relevant. And this is the reason why we are no more talking about collateral closure rather than Fontan fenestration creation. In the past, we closed effectively Fontan fenestrations, but in long-term follow-up is not common. We to need an opening of that fenestration. So we have 3 of our 12 Fontan fenestration that we performed with AFR in the past 2 years that were re-fenestration after Fontan closure performed a decade ago, more or less. You know that some cutoff are available to decide if to leave the fenestration rather than to proceed with the closure of the fenestration. But I think that currently the problem is where to leave the fenestration rather than to close at all the fenestration. So this is a recent example. We had the saturation in this patient, but as you can see, the patient still showed a ridge so a kinking in the Fontan conduit and a kink in the left pulmonary artery. Thus, we decided to put 2 stents in this patient, to a stent in left pulmonary artery to improve the flow across the left lung, and to put a stent in the Fontan conduit, but without covering the Fontan fenestration, that was still patent and still there because that position is effective for liver decompression rather than veno-venous fistulas. So fistula can be sometimes huge. We had a recanalization of azygos vein in coronary sinus. And the first time we placed the vascular plug 1 here on the high in the fenestration, but after 3 years after, we found a recanalization of that fistula, and for this reason we put a second device. It was quite difficult because the way was across the aorta, passing through AV valve, coronary sinus, and we put here lower in coronary sinus the vascular plug. In the coronary sinus, it's not true. Is a posterior cardinal vein before the true coronary sinus, of course. Otherwise, the venous drainage of the heart might be impaired. You can see true coronary sinus here. We stayed above it. This is another example. So you can see that this kind of fistula from the recanalization of cardinal vein is quite common in Fontan tract, and for sure it's relatively easy to close them because it's a quite straight way, so it's easy to cross with catheters, Mullins, and guiding catheters. So this is a special case where this was a patient with a massive AV fistulas in the left lung. So, what's your opinion in this setting? What's your choice? To leave surgical lobectomy, uh, further embolization? What's your choice in these patients? What's your experience in these patients?
Gracias,
Can you?
doctor, por la pregunta. O sea, en estos casos no he tenido un caso como de estos en pacientes con fisiología univentricular y Fontan, pues que hacen este tipo de fístula. Lo tuve fue paciente, otro tipo de paciente que solo tenía malformaciones arteriovenosas y como son muchas, pues yo lo mandé a cirugía. Pero en pacientes univentriculares no he tenido la experiencia de tener este tipo de pacientes. Me parece muy eh, eh, pues esa imagen que impacta mucho la gran cantidad de coils que, que usó para embolizarlos. Lo felicito.
So we had a couple of cases like this. So our choice in these patients is to put a huge device like to create a. You can see that there is a snow here because the left lung was full of fistulas. So we decided to exclude the inferior lobe of the left lung with a huge vascular plug. And you can see that after this maneuver, the left lung was almost excluded, but the patient's saturation improved. We were about 65% baseline, and we improved up to 87, 88 after the procedure, and the result was maintained in the last 12 months. We did it 1 year ago, more or less. So we are approaching these patients with a percutaneous embolization. So we try with selective embolization first, but once the AV fistula results disseminate, we do a lobar closure with the device. So arterial embolization can be a point in these patients. Of course, the indication is when the arterial fistula, systemic pulmonary fistula, increase pulmonary artery pressure or determinates left single ventricle dysfunction as well. But this is a case that I want to show you. We had a huge fistula between the azygos system toward the left atrium, so through the pulmonary veins, of course. The fistula was the fistula feeding was from the top and from bottom, so from azygos, but also subdiaphragmatic vein draining in azygos system. In this patient, the hole was too large, so we decided to put a covered stent here because the risk of you saw in the previous case the risk of recanalization of the fistula in this case was high. So we decided to put a cover stent like it was a break in the azygos wall, and we restored the continuity of azygos by excluding the left pulmonary vein that was anastomized with the azygos. But in this patient, it was essential to create a fenestration because otherwise the puncture was the pressure becomes too high. For this reason, we started with the AFR implant. You can see here we are in the middle of the right atrium, echo-guided. We found the correct position. Usually, a left anterior oblique view is ideal in this setting. We punctured and we passed in the left, functionally left atrium. Once in, we advanced with a stabilizer, so a stiff but coronary sized guide wire. And on that coronary guide wire, we started to dilate the hole that we created with the needle. First, we use the standing balloon that you know is a very low profile balloon. With around the 3 French, so it's easy to is a very an excellent trackability. And after the first dilatation, we dilated also with the Dorado balloon, that is a non-compliant balloon that can achieve a better result. Of course, once obtained the fenestration by balloon, we stabilized it with the device that can be easily employed. So you can see that once achieved the tension on the left side, I moved in the same way, pull back the delivery sheet, keep the tension on the right disc. Once the right disc is all outside the sheet, advance with it. And you can see that the stent remained flat and the central opening was absolutely straight and adequate. Finally, of course, we can consider also drugs. I think that you already know about this. Just to know, we are starting to use glyphosines in this patient when PILI is resistant to conventional drugs, and we found them very helpful to fight PILI in long-term Fontan complicated by this issue. So, in conclusion, we can say that right heart catheterization plays a central role in ventricular physiologies. I think that fenestration are important in high risk Fontan. We currently are moving to creation of fenestration into the Fontan conduit, and in the same time the closure of the fenestrations of veno-venous fistulas, because a lower fenestration is more helpful for the liver and for the gut so is more effective to reduce subdiaphragmatic pressure. And the closure of veno-venous fistula are effective to compensate a little bit and to stabilize the saturation, to avoid too low saturation that it means cyanosis related problems, abscess, polyglobulia, pulmonary infection, bleedings, and so on. Thank you for your attention.
Doctor Castaldi, muchas gracias. Tenemos preguntas en este momento para el doctor.
Hola Mauricio, buen día. Yo quisiera aprovechar
Hola,
la
doctor,
opinión
¿cómo
del
está?
doctor. Nosotros tenemos pacientes que por alguna razón llegan tardío al Fontán. Entonces van con muchas fístulas o malformaciones arteriovenosas pulmonares. ¿Cuál es el límite? O sea, ¿eso los limita a ustedes para avanzar al Fontán o lo hacen y esperan que por el tema del factor hepático eso disminuya. Cuando son difusas, porque cuando son localizadas o bien precisadas, pues uno puede embolizarla como usted las mostró, pero cuando son difusas, esa sería mi pregunta. ¿Qué experiencia tiene usted? Imagino que no le llegan pacientes tan tardíos, ¿no?
So yes, I know that some like that patient, the fistula were all involving the left lung. Of course, we tried to improve as possible the flow from hepatic veins to the lungs, but you can do it up to a given point. Unfortunately, in that setting, the patient had a left Kawashima, so the liver was directed preferentially to the right pulmonary artery, and the remaining blood was directed to the left, and it was the trigger for the development of this kind of disease. Unfortunately, I don't know if you have other ideas, but we didn't find any other way to improve uh, uh, this situation. So the patient was heavily symptomatic for this, and we decided to functionally exclude the diseased lung. But of course, when you can, the extracardiac conduit stenting or anticipating the Fontan completion, taking care about the direction of the conduit that should be in the middle between the two arteries. Of course, that choice should be the first choice, but it was not that case because Fontana was already did, and to redo a Fontana in this setting is quite hard.
Y en el otro aspecto, cuando decide cerrar la fenestra del Fontán, ¿qué parámetro usa? Porque le preocupa a uno es que después ese Fontán falle y cerremos la única ventana de escape de presión que tenía.
So in the past, we closed when the pressure was above 15, either baseline, of course, but also after Fontan fenestration occlusion test, you can just use a Schwann-Ganz balloon and pull back up to achieve a closure. But nowadays, I think that if a fenestration is still patent, there is a reason, despite you cannot see it. So we no more close frontal fenestration as you saw. We stent the conduit, but without to close the fenestration. We use open cell and bare stents because the fontan fenestration is the best placement, the best place to have a fenestration in fontan track. Sometimes you close it, but once closed, veno-venous fistulas appear, and veno-venous fistulas are worse in terms of decompression because comes from the neck that is in negative pressure. So the fenestration appear where are not needed. We need something decompressing the lower part of the body rather than the higher part of the body. So we no more close frontal fenestration here.
Ya, perdón, y una última. ¿Qué experiencia tiene dilatando el tubo de Fontán? A pesar de que usted no vea una estenosis puntual, por ejemplo, esos Fontán que se hace muy temprano y el tubo se queda chico después. ¿En qué situación lo dilatan?
We dilate the Fontan conduit every time we find a stenosis. So we don't care about the pressure because sometimes pressure can be low despite the stenosis. The diagnosis and the approach is anatomical. If we have any kind of stenosis, kinking, flap, we always stent it. Of course, if the stenosis is too tight, I prefer a covered stent. because we can have sometimes a breakage in the conduit that sometimes maybe a calcification that can be fragile. Otherwise, a bare stent is enough. So we stent at any anatomical stenosis. We don't care about pressure. Sometimes the sentinel is the dilatation of the suprahepatic vein or inferior vena cava just below the fontan conduit, because that part is the only the native tissue is the only compliant part. If we have the inferior vena cava cuff dilated, it means that there is a stenosis into the conduit, and we move to a second level image after this aspect by echo.
Gracias.
Gracias, doctor. ¿Alguna pregunta adicional? Vale. Doctor Castaldi, de parte de IMP, agradecerle tan excelente presentación. Sabemos lo complejo que es el uso de dispositivo en esta patología tan difícil, pero creo que cumplimos y logramos la expectativa que teníamos desde Colombia. Alejandro, a Marco, agradecerle el espacio. Esperamos seguir contando con esos espacios de conocimiento tan importantes. Y a todos nuestros médicos en Colombia, muchas gracias por su participación tan activa. Nos estamos viendo en la próxima. Muchas gracias. Feliz día.
Gracias, Mauricio.
Gracias,
Thank you so
Mauricio.
much, doctor Castaldi.
Muchas gracias,
Grazie
Alejandro.
mille.
Gracias a todos.
Hasta luego, gracias.
Buen día.
Bye bye.